In Module 2, we discussed the steps to take to assess for the presence of opioid use disorder in a patient who screens positive. Topics will include the DSM5 criteria, the 4 C's, characteristics of addiction, and assessing readiness for treatment. So as we alluded to in the previous module, substance use disorder exists now on a spectrum. This is very different than the old DSM thinking about addiction as being either abuse or dependence. Rather than these discrete categories, this really reflects our current understanding of substance use, that it's a spectrum from low risk to severe, moving from left to right, increasing amounts and higher risk substances to the development of actual craving, loss of control, and consequences. So understanding where for the person who's screened positive, understanding where they fit on the spectrum is an important task for the clinician. Substance use disorder and DSM-5, as we previously discussed, there are 11 criteria, and you would categorize in an assessment their impaired control, social impairment, risky use, and physiologic manifestations, these 11 dimensions, and it's sort of a count from mild, moderate to severe. And typically those who have moderate to severe are folks that we strongly consider for medication for opioid use disorder. If the person meets DSM-5 criteria, it's often a challenge to help them accept the diagnosis that they've had a pain condition and now I'm concerned that they have another condition, opiate use disorder. It's important that you assess their understandings of what the harms are they've experienced, their readiness for treatment. You're going to enter a process of negotiating with them about what kinds of treatment folks will accept. And the thing to remember is that engagement, working with the person over time, really is one of the most important things that you can do for these patients. Sometimes folks won't meet the full criteria, but if you think the opioid use is problematic, it would be useful for you to increase the structure of treatment, either by seeing them more often, giving them shorter prescriptions, increasing the amount of monitoring, urine testing, etc., augmenting the non-opioid modalities and support in terms of their pain management, and considering whether or not a taper, is appropriate, particularly if you're not seeing a lot of functional benefit from the medication. If you're not seeing benefit and they're continuing to display a risky behavior, that would be an indication that maybe this is not an appropriate medication for them. Readiness for treatment is important to assess, and a sort of a quick way to do this is to ask someone on a scale from 1 to 10, 10 being very much, how much do you right now want to stop using? And if the person, for example, 10 being very much and 1 being 0, the person says 3, for example. The question that we naturally want to ask is, why are you not a 10? But that's not the question that should be asked. The question should be asked is, why are you not a 0? In other words, why are you not totally unready? Because in some ways they said 3 because they recognize that there may be something about it. And so if you can get them to articulate what it is they're concerned about that made them a 3, that's what's called a self-motivating statement and can help move them along in terms of their readiness. Another question you could ask is, what would it take to get you from a 3 to a 6? Again, a 6 is not a 10, but to be a little more ready, and what kinds of things we can do. And you can do similar things around confidence, particularly for those who've tried to quit before but haven't been successful. They often lack confidence. And a lot of your work as a clinician is going to be to sort of be a coach for them, to inspire hope, to let them know that they can do this, and to sort of work with them to help move them forward. There are other needs that you're going to want to consider in your assessment as you're thinking about what treatment plan is going to be appropriate. The American Society of Addiction Medicine, or ASAM, has a series of criteria, formerly called the patient placement criteria, that can help guide thinking about the treatment plan. And they define 6 sort of areas that you want to think about in defining what kinds of services a person might need and what kind of setting they might need in order to enter recovery. So what is their potential for acute intoxication or withdrawal? So if they're acutely intoxicated, you're going to want to stabilize. If they're early on and they're going to potentially develop withdrawal, you'll want to manage those symptoms, put them in a setting where those symptoms will be able to be managed. Similarly, if they have biomedical conditions or complications from their use, those will need to be managed. Those both are a risk to their health, but they also can be things that will trigger relapse, particularly pain or other kinds of symptoms. Do they have emotional, behavioral, cognitive conditions or complications? So this sort of speaks to their mental health state. Very common for there to be co-occurrence of mental health conditions and substance use disorders, and often those emotional issues can be triggers for use. So when someone feels sad, they use. When they feel depressed, they use. So you again will want to address those issues either yourself or referring them to an appropriate provider or setting that can address those issues as part of their treatment plan. Readiness to change, we sort of talked about that. You want to assess what their readiness is and how often you're going to see them and what kind of structure they need in their treatment. That will determine their continued use or continued problem potential. So again, have they had multiple relapses in the past? Are they hopeful and confident about their ability to do it this time? And depending on what you assess in that area, you may or may not need, a residential or a more structured setting for them. And finally, the domain that I often turn to as being the most important to think about, if you were to just pick one, for me, it's recovery environment. And recovery environment has 2 dimensions. It's structure and it's support. So structure sort of refers to the idea that do they have something to do every day in a structured way? That's sort of the addiction medicine version of idle hands are the devil's workshop, which is to say that if the person doesn't have structure, doesn't have something to do every day, they're going to get into mischief. So employment is really, really important, and that's probably the best thing that they can do, but it's often challenging for our patients. So we often substitute meetings or treatment as something stable for them to do that's highly scheduled. The supportive dimension refers to the kind of environment they live in. Are there other people using drugs? Is their family and friends, are their family and friends supportive of them entering recovery, or they don't have any people in their social network who don't use? Typically those folks, again, recovery groups like AA can be useful as a place for those folks to go to meet people who are sort of struggling with the same issues that they are, and to try to meet folks who are sort of on their way to sobriety as opposed to continuing to use. And the other question you need to ask yourself is whether the needs of this patient can be met by the resources that you have. And if not, then you need to look around your community for resources that will be able to help this patient. The CDC guideline recommends assessing overdose risk. This is more important than ever now, given the fentanyl that Dr. Gaberman talked about out there, very high overdose risk. People on their first relapse can die, so we want to be sure they don't. So folks who've had prior overdoses, all our patients with substance use disorder, those using high daily doses of prescribed opioids, those who are switching if you're doing rotation, any prescription benzo or sedatives or antidepressants, those with respiratory issues, or anything that can affect metabolism. All of those folks, you really need to assess their overdose risk. We're going to talk about that a little bit more in one of the future modules. But it's sort of a good time for us to speak to a case. And Dr. Gaberman has brought a case that would be good for us to talk a little bit about.
Continuing a new patient, so this case is about a patient newly presenting to you. Continuing this patient on opioid analgesics, which were previously prescribed, requires investigation to verify doses and safe use. Abruptly stopping the pain medications of a new patient would throw that patient into withdrawal and should not be done. But before writing a script, it is essential to check the prescription drug monitoring program. There are times when the patient's old prescriptions do not show up on this, possibly because she or he's coming from another state. But then it's important to contact the patient's old prescriber or pharmacy to verify the dosing. The patient's high dose of oxycodone in this case raises a red flag, as it seems very high for a chronic condition that even when severe can often be brought under control with biologics. However, the limited information we possess in this description does not suggest a substance use disorder. To investigate this further, we would need to review old records of RA treatment and disease control, as well as prior pain medications tried, doses used. And we would also need to speak with this patient about psychological comorbidities, social stressors, day-to-day functioning, and send a urine toxicology screen. As Dr. Friedmann reviewed earlier, signs of impaired control, social impairment, and risky use are really necessary before diagnosing substance use disorder. Even without a diagnosis of substance use disorder in this case, after getting to know the patient better, I would recommend planning a slow taper down to a safer daily dose. Dr. Friedmann just reviewed the CDC's recommendations for preventing overdose with opioid use. This patient's total daily dose of oxycodone, 105 milligrams, is equivalent to 160 milligrams of morphine, using a factor of 1.5 to make this conversion from oxycodone to morphine. A morphine equivalent daily dose of 50 milligrams, and especially over 90 milligrams, poses a marked increased risk for overdose. Indications to taper the opioid dose here would be lack of a significant improvement in pain and function over time on this dose, and a daily dose over 50 milligrams morphine equivalent. But remember that tapering plans should be individualized and discussed with the patient and minimize symptoms of withdrawal while maximizing non-pharmacologic therapy and non-opioid medication. Tapering 10% of their original dose per week can be done, but patients on chronic opioids usually need to go slower, and they will often find a decrease of 10% per month much easier. Tapering should be done in coordination with the patient's rheumatologist in this case, and with appropriate psychosocial support. You will often find that tapering does lead to improved function without worsening pain. And you may be surprised that sometimes patients even experience less pain over time.
John, does the fact that she says that the only effective treatment, often that phrase, we have patients who come in and ask for only Dilaudid works for me, or only this, or only that. Do you find that to be a red flag in working with folks like this?
I do, but I also try to step back and be careful and respect what the patient's saying and take it at face value, but know that I need to do further investigation. And that's why I mentioned it's very important to not only check the PDMP, but to really try hard when a patient's on such a high dose of opioids to speak to the prior prescriber, to find out from the pharmacy what the pattern of use was.
Great. Well, in summary, if the person screens positive, you're going to need to assess for substance use disorder, for example, opioid use disorder. As part of that, you'll want to understand their readiness for treatment, their severity and treatment needs, particularly in other domains that can affect the course of their recovery. and you'll need to make a decision about whether you can treat those needs yourself or whether you're going to need to make a referral for appropriate services. And as Dr. Gaberman and I have both emphasized, it's really important in this day and age that we assess overdose risk, and as we'll talk about in future modules, that we address that risk.